Okay, so the last topic for today is orthopedic appliances. So when we talk about orthopedic appliances, we mainly talk about face mask, headgear, reverse pull face mask, chin cap, these kind of appliances. So we will be talking about the different types of appliances, the duration of wear, the amount of force they generate, what is the design, and in what are the indications and contraindications of them. So for a best result in case of a class 3 malocclusion correction, the orthopedic appliance should be worn for at least 12 to 16 hours a day. So no matter what the appliance it is, whether it is chin cap, face mask, whatever it is, it should be worn for at least 12 to 16 hours in a day. Now orthopedic appliances, they generate very heavy forces of well above 400 grams per side. Okay, the force magnitude has to be high. It is around 400 to 600 grams per side, and when you take a total of it, it is around 800 to 1200 grams per side. That is 2 to 3 pounds. To make sure that mainly skeletal effects take place and not dental, because we mainly want a skeletal kind of a change. They are usually recommended in the evening because of the release of the growth hormone is greater at that time. So what we can advise the patient is that, suppose once the patient comes back from school or work or whatever it is, start from evening, for example maybe 6 o'clock in the evening, go on to next day 6 o'clock or 8 o'clock in the morning. So that is the ideal time. And also you don't need to wear it to work, you don't need to wear it outside. So as far as aesthetics is concerned, there is no compromise. Orthopedic forces are heavy intermittent forces, like I described. Means that the force doesn't decay to zero, but the force in between, it stops because obviously the patient takes out the appliance. Such high forces compress the PDL, producing hyalinization leading to undermining resorption, prevents tooth movement, and thus only a purely orthopedic movement is achieved. The most optimum treatment time for using an orthopedic appliance is the maturation stages between SMI 4 to 7 according to the Fishman's index, in which basically you reach the peak high velocity. Now this is the accelerating slope of the peak prepubertal growth spurt. So whenever you give an orthopedic appliance, whether it is a chin cap or face mask, first you must identify what period of growth the patient is in. If the patient has not achieved the prepubertal growth spurt or has gone much beyond that, then chances are that this kind of appliance will not really be effective. A high pull headgear is used to intrude the maxillary incisors and correct an anterior deep bite. Again, because of the direction of forces that are applied onto the maxilla and the maxillary teeth. Now, I have made a chart again, which is going to come towards the end. It will make these things a little bit clearer. A high put or parietal headgear or a vertical put headgear, it derives anchorage from the parietal region. It produces intrusion of the maxillary anterior teeth if the line of force is perpendicular to the occlusal plane in the anterior segment, and it also causes counterclockwise rotation of the maxilla and intrusion of the anterior. So when you take the maxilla and you talk about counterclockwise rotation, there is intrusion. So this kind of force vector is generally used in cases of anterior vertical maxillary excess. That means the height, anterior height is more, and therefore because of the excessive height of the maxilla, you see a patient with a gummy smile. So when the patient smiles, apart from the anterior teeth being visible, there is a large amount of gingival visibility also. If the line of force passes in the posterior segment, it results in a clockwise movement of the maxilla and intrusion of the posterior teeth. Then there is something called a cervical headgear. It derives support from the nape of the neck, and this causes extrusion of molars, and so it is indicated in patients who have deep bite and a lower mandibular plane angle, again because the line of force is below the level of the occlusal plane. The main drawback of a cervical headgear therapy is again extrusion of upper molars. So in case you have a patient with a high MPA, this kind of a headgear should not be used. A headgear, when properly constructed, can move a permanent maxillary first molar crown in all kinds of dimensions, either laterally, vertically or mesiodistally. A reverse pull headgear, that means what is the one which is used for protracting the maxilla, is used mainly to induce the growth of maxilla in a case where there is maxillary retrusion, mainly in class 3. So this kind of a reverse headgear derives its anchorage from the facial region, and this is also called as Nakamura appliance, named after the person who discovered it. Now, appliance of choice in cases where there is anterior-posterior maxillary deficiency is a reverse pull headgear. Now, you must not get confused between your face mask and headgear and chin cap and reverse pull headgear. Your headgear is the regular headgear which you use, occipital pull, parietal pull, vertical pull, that kind of thing. That is used to restrict the maxilla when especially there is a class 2 malocclusion or a class 2 skeletal pattern. The opposite, that is reverse pull headgear, actually pulls the maxillary dentition and the maxilla forward. That is used in case of maxillary deficiency in class 3 patients. So there is a regular headgear which is your cervical, occipital or parietal, which is used for class 2, mainly to remember that, and a reverse one is used for maxillary deficiency for class 3. A chin cap is used to correct a class 3 malocclusion. So basically your chin cap along with your reverse pull headgear is a modality of treatment for class 3 malocclusions. So chin cap was particularly useful in treating class 3 skeletal discrepancies with a mandibular prognathism. It was introduced by Oppenheim and it delivers a force of about 800 to 1200 grams on both sides. The patient is asked to wear the appliance again for 12 to 14 hours in a day, and this much, when you want to redirect the growth of the mandible, you can use a little lesser force, that is around 800 grams, and when you want to stop the growth or rather not let the mandible growth any further, you can use a larger force, that is 1200 grams. Now unfortunately what happens is any kind of orthopedic treatment in case of class 3 malocclusion or a class 3 kind of a problem is extremely prolonged, because firstly you are using this kind of an appliance mainly in a pubertal growth spurt, so you have to wait for that age. Till that time the patient already has the full-fledged or almost full-fledged form of the malocclusion. After that also, even after you remove the appliance, even if the patient is not still in that accelerated growth phase, there is some amount of relapse that takes place. So whether you use 800 grams or you use 1200 grams or whatever it is, you can only stop the growth for some amount of time as long as the appliance is placed. The moment you remove the appliance, the mandible, some amount of relapse happens and the mandible starts growing back. So this doesn't mean that once you put this, it is stopped completely, because as we have studied in growth and development, when you compare maxilla and mandible, the mandibular growth is much more prolonged and for a longer duration than the maxilla. So this is one of the greatest disadvantages in treating class 3 malocclusions. Now this kind of a treatment is very successful in patients who can at least bring about their incisors to an edge-to-edge position, if not a proper overjet and overbite, and also centric relation. Now the occipital pull chin cap will result in a lingual tipping of the lower incisors because of the direction of the force. So mainly they are indicated in patients with a slightly protrusive or proclined lower incisors, because when we use it in that, then at least with the amount of force they get uprighted. Vertical pull chin cap is indicated in patients with a steep mandibular plane angle and an excess anterior facial height, and these patients usually exhibit an anterior open bite. So you try to limit that amount of increase in the anterior facial height. When a protraction headgear is used, most of the orthopedic changes are observed within the first 3 to 4 months. Again, protraction headgear is nothing but reverse pull headgear. So the length of the treatment varies between 3 to 16 months. The best time to start is at the time of the eruption of the permanent centrals, and the headgear, protraction headgear, is generally worn for 8 to 12 months on a full-time basis for ideal results. The maxilla can be advanced by around 2 to 4 millimeters in a period of 8 to 12 months. The minimal duration of wear. See, whether we talk about protraction headgear, occipital pull headgear, chin cup, whatever that is, none of these should be used less than 12 hours. It has to be at least 12 to 14 hours, preferably even more than that, sometimes 16 hours also, but never less than 12. Most of the orthopedic changes are observed within the first 3 to 6 months after maxillary expansion takes place. But this is only the active part of the treatment. After this part comes the retention part of the treatment, where you have to keep the appliance in place. It is passive, so as to decrease the relapse tendencies. Only for forward translation, the direction of pull should be 15 degrees below the occlusal plane, and for forward and upward translation, the direction of pull should be in the parallel to the occlusal plane. So generally, because of some amount of relapse that takes place, we tend to overcorrect the changes taking place. So overcorrection of skeletal relationship is achieved within this time period. So once the active part is achieved, we overcorrect it by a couple of millimeters or so that even if relapse takes place, it goes back to an ideal relationship. So when this overcorrection is achieved after the active phase, when the appliance is only worn for retention, then it is worn at the 9 time for an addition of 6 to 12 months to retain the changes. The amount of force required to effect the mandibular changes at the condylar region is around 4 to 5 grams per square millimeter. Now there is a calculation through which we come to this particular value, and that is, now we have to take the measurements of the shape of the condyle. Since it is oval, it has a minor axis and a major axis. The major axis is the longer one, the minor axis is the smaller one. So the minor axis is usually 8.5 to 10 millimeters, and the major axis is around 18.5 to 20 millimeters diameter. So you calculate the surface area of the condyle by the formula, that is pi, which is 22 by 7 into minor radius into major radius. So if we take the maximum values of the minor and the major radius, that is the diameter, suppose we take 10 millimeters and 20 millimeters. So according to this calculation, it is 22 by 7 into half of 10, that is 5, and half of 20, that is 10. So you get around 150 square millimeters roughly. Suppose we take the minimal values, we get approximately 120 square millimeters. Now 120 square millimeters is the area. If we divide the amount of force, that is 600 grams or so, by, you can take either 120 or 150 square millimeters, we get around 4 to 5 grams per square millimeters. So that is how we come to how much of force is applied at the condyles. Now a patient in a mixed dentition stage comes for treatment. He has class 3 skeletal malocclusion, he's got an open bite, SNA is less, it is 78, SNB is more, that's 82. So the choice of treatment would be a vertical pull chin cap, again because of mandibular prognathism and increase in SNB, and a reverse pull headgear because of the decrease in SNB and the maxillary retrusion. Now vertical pull chin cap also because he presents with an open bite. So depending upon the type of class 3 malocclusion, whether maxillary retrognatism is present or not and mandibular prognathism is present or not, we describe the treatment option. So patients who come with a vertical growth pattern we usually give a vertical pull chin cap. So vertical pull headgear or chin cap is given in prognathic maxilla with deep bite cases as well as open bite cases depending upon the line of force. So these all are the same type of treatments. Next is a headgear applied to the maxillary molars can serve to improve the anterior-posterior skeletal dysplasia by redirection of the maxillary growth. RME cannot happen with a headgear. Neither can the posterior repositioning of the maxilla or the downward and backward rotation when we talk about this kind of a headgear. So mainly it is a redirection. Which direction depends upon what kind of headgear you are using. So unless it is not mentioned, you can take the option of just redirection of the maxillary growth. The sutures connecting the maxilla to the cranium and the cranial base, they are more or less parallel to each other. So this allows the downward and the forward repositioning of the maxilla as the growth occurs in the sutures. The forces which are applied to the maxilla compress this and restrict its downward and forward growth, and when at the same time the mandible is allowed to grow normally. So again, like previously discussed, forces range between 350 to 450. Now sometimes you might see that there is 400 to 500, sometimes there is 400, sometimes there is 350, 450. So mainly it is in a range. You cannot say that it is only 450 or it is only 400. So sometimes it is 350 to 450, sometimes it is 400 to 600, but usually not around the range of 400. Again, for 12 to 14 hours in a day. This has been also discussed, the amount of force required for what kind of treatment, and headgears, apart from bringing orthopedic changes, they also bring about dental changes like distalization of maxillary molars, extrusion of the molars, and intrusion of the maxillary anterior teeth if given with some removable plates. Now all of the following directly result from a cervical pull headgear therapy except increase in the forward growth of the mandible. Usually it has a direct effect on the maxilla rather than the mandible. But in cases of combined maxillary prognathism and a retrognathic mandible in a class 2 case, a headgear is given along with an activator so that apart from stopping or redirecting the maxillary growth, you also allow the mandible to grow. Again, the forces applied are 200 to 400. This has been discussed. Now a face mask is used to treat maxillary retrognathism and mandibular prognathism. In other words, class 3. A combination type of class 3 which is common, which is maxillary deficiency and mandibular excess. This is the most common type of presentation of a class 3 malocclusion. In this type, growth modification procedures are exactly reverse in what you do in class 2. That means you restrict the mandibular growth and try to redirect the maxillary growth forward. Here you have a reverse pull headgear in which you pull the maxilla forward and a chin cap that stops the excessive growth of the mandible. So such a combination is called a face mask. Now headgears which cause a forward pull on the maxilla, these are called reverse pull headgears because the actual action is to stop the growth of the maxilla. So when you reverse it, it's called a reverse pull headgear used for class 3. This type of headgears, they exert a tensile force, that means stretching at the craniomaxillary sutures, and they were started or popularized by Hickam. But it was also later on modified by Delaire, and the Delaire one is the commonly used reverse pull headgear that is used nowadays. So this is the face mask by Hickam which was initially used, and this one, the black and white one, is a Delaire face mask, and there is also a Petit kind of a face mask. Out of these two, the Delaire one is little more common. In a reverse pull headgear, it can be best described as tensile and ventral. We are talking about tensile and ventral as far as the forces are concerned. Now tensile, when we talk about dorsal ventral, it's the same as dorsal ventral surfaces of the body. Dorsal is the posterior, ventral is the anterior. So the reverse pull headgear, it produces a stretching kind of force, not a compressive force. Therefore, it is tensile. And since the commonly used cervical occipital headgear produces forces from the back of the head or dorsally directed. So therefore, it is dorsal and tensile. Skeletal class 3 malocclusion in growing children is treated by all of the above. Now, a common confusion might be, it can be only A, it can be only B, it can be maybe A and B or B and C. But in this case, it has to be done in a sequence. Therefore, it is all of the above. So, what happens is, when we talk about class 3, let's take a combination situation where there's a prognathic mandible and a normal or a retrognathic maxilla. So here, in this case particularly, you need a chin cap because you need to stop the mandibular growth. You need a reverse pull headgear to bring the maxilla forward. And at the same time, in class 3 patients, you will also observe that the maxilla is very, very constricted. So you start with the phase of RME, where you expand the maxilla. After expansion of the maxilla happens, after the active phase is over, and then you keep the expansion and the RME in place, there are, we incorporate 2 hooks into the RME, especially when the hyrax, when it is bonded. And to that, the elastics of the reverse pull headgear or the face mask are attached. So it is basically in an order. You start with your expansion, and then the face mask, which is the reverse pull thing with the chin cup, is done. Again, the amount of force when we talk about chin cap is 1000 to 1200. This amount of force, 2 to 3 pounds, is equivalent to 800 to 1200 grams, 12 to 16 hours in a day, is required to effect the desired changes in the mandibular growth. A force of 500 to 1000 is required to effect desired changes in the maxillary growth. So basically, you need more force for stopping the mandibular growth than in the maxilla. Which of the following are true in case of a chin cap? It is all. If you apply a larger force, you use, the time duration should be less, and if you apply a lesser force, the time duration should be more. And then it has to be worn for 24 hours a day to correct a severe prognathic mandible. Now this usually happens in very rare cases, but just keep in mind that sometimes 24 hours can be used, but again the forces have to be very, very less. At the time of appliance delivery, the force is around 150 to 300 grams per side. Over the next 2 months, the force is gradually increased, because sometimes the patients have a very low tolerance level. So you can't suddenly start with 500, 600, 700 grams. So you start with very low forces. So after 2 months, you increase it to around 450 to 700 grams per side. Then, and you start with maybe not 12 to 14 hours, but at least start 10 to 12 hours. Then gradually, as time passes by, increase the duration to 16 to 18 hours, and then you decrease the force level to 200 to 400 grams per side. Then the patient is strictly advised to wear the appliance for the duration that you usually use the appliance for, 12 to 14 hours a day. Now, as far as chin cup is concerned, there is a classification of chin cup which is according to the direction of pull, that is occipital pull and vertical pull. The occipital pull chin cap is, the direction is towards the occipital part, and the vertical pull chin cap is again vertical in direction. According to the Unitech design, again vertical pull chin cap is classified or divided into 2. There is a Unitech design which is like this. This is the view, and this is the summit design. So rather than learning how the designs are, if you just know there is an occipital and a vertical pull, that is more than enough. So that is the end. There are no questions at all. Okay, that's it.